Good morning, students. Today we will see an overview of endocrine physiology. The first will give pituitary gland. So pituitary gland is of two parts. One is anterior pituitary, other one is posterior pituitary. The anterior pituitary secretes growth hormone, prolactin, TSH, that is thyroid stimulating hormone, FSH, follicle stimulating hormone, LH, luteinizing hormone, ACTH, that is adrenocorticotrophic hormone. And posterior pituitary only two hormones. One is oxytocin, which helps in milk ejection and uterine contraction during delivery, and ADH, that is antidiuretic hormone, also called vasopressin. It increases the water reabsorption and causes vasoconstriction of the blood vessels and increases the blood pressure. And coming to the growth hormone is secreted from anterior pituitary and it helps in the growth. Okay, so most of the effects of growth hormone on muscles and other peripheral tissues on bone are exerted through insulin-like growth factor IGF-1, which is an intermediate secreted from the liver. This IGF-1 is also called somatomedin C. And the growth hormone increases, other action of growth hormone, it increases the blood glucose level and it utilizes the fat for energy. Okay, so it increases the lipolysis, and protein, it helps in the protein anabolism, okay, protein building. And the mechanism of action is mainly through the membrane receptors, and which follows a pathway called Janus kinase STAT pathway. And excess growth hormone before the puberty leads to gigantism. Person with tall stature will be there, and excess growth hormone after puberty, that is leading to acromegaly, that is after fusion of epiphysis. Acromegaly, the distal ends of the limbs, that is in the fingers and the toes, will be enlarged, and the membranous bones will be enlarged, like bossing of the head, frontal bossing will be there, and prognathism, protrusion of the mandible will be there. And deficiency of growth hormone leads to short stature. Okay, and this dwarfism, we call it as pituitary dwarfism. And coming to thyroid hormone is secreted from the thyroid gland, and we have the thyroid gland contains follicles, and there are various steps in the synthesis of thyroid hormone. The important raw material is the iodide. So from the dietary iodide, the iodide from the blood enters into the thyroid follicular cell, which is called thyrocyte, and from thyrocyte it enters into the colloid. Okay, the colloid contains the important protein called thyroglobin, which is synthesized from the thyroid follicular cells. So this iodide is exchanged for chloride by the transporter called iodide chloride export transporter or exchanger, which is called pendril. Okay, now this iodide which enters into the colloid gets oxidized to iodine by the enzyme thyroid peroxidase, and the iodine gets incorporated into tyrosine, and this process is called organification, and it forms monoiodotyrosine and diiodotyrosine. And these monoiodine and diiodotyrosine, they go for coupling and they form T3 and T4, and everything is taking place in the colloid. And once everything is formed in the colloid, this colloid is taken again by the thyroid follicular cell and by the process of endocytosis, and once enters the thyroid follicular cell, they get degraded, and the T3 and T4 will be released into the blood by the process of exocytosis. And in the blood, they get transported along with plasma protein and also in free form. There are thyroxine binding globulin and thyroxine binding prealbumin. Then once they reach the target tissues, they enter the cell membrane because they are lipophilic, and they act directly on the nuclear receptors, and they alter the nuclear function, gene transcription, and they exert their actions. And what are the actions of thyroid hormones? It acts on all the system of the body, starting from the head, starting from the central nervous system. It helps in the myelination of the neurons, and in the cardiovascular system, it increases the heart rate and increases the force of contraction, and in respiratory system, it increases the respiratory rate. In GIT, it increases the peristalsis, and it is also important for the reproductive functions. And the lack of thyroid hormone leads to cretinism in children and myxedema in adults. Myxedema is the swelling of the body due to deposition of mucopolysaccharides, and because they require thyroid hormone for the metabolism. So there will be accumulation of mucopolysaccharide like hyaluronic acid, and that leads to edematous or swelling all over the body. And this cretinism, the kids will be of short stature, and the mental retardation will be there. So hypothyroidism is one of the preventable cause for mental retardation. It's a preventable mental retardation that can be prevented. And when the hormone level goes high, we call it as hyperthyroidism. And hyperthyroidism has many features like tachycardia will be there, pulse rate will be very high, and sweating will be there, and exophthalmos will be there. Exophthalmos is a protrusion of the eyeball, and this is a classical feature of Graves disease. Graves disease, which is characterized by exophthalmos. And the cause for exophthalmos is there will be retrobulbar proliferation of tissues in response to the thyroid hormones, excess thyroid hormones. So this is regarding the applied aspect of thyroid hormone. Then coming to the pancreas. So pancreas of two portions, one is exocrine and endocrine. The endocrine part of pancreas is called as islets of Langerhans, which consists of 4 cells: alpha cell, A cell, B cell, delta cell, and F cell, A, B, D, F cell. The A cell secretes glucagon, B cell secretes insulin, and D cell secretes somatostatin, and F cell secretes pancreatic polypeptide. And coming to the insulin action, the insulin has action on 3 areas. One is the muscle, adipose tissue, and liver. In muscle and liver, it forms glycogen. It increases the glucose uptake and forms glycogen, and also protein. It helps in the protein formation in muscle and liver. In adipose tissue, it causes glucose entry into the adipose tissue and forms glycerol phosphate, and it leads to formation of triglycerides, that is storage form of fat. Also, it inhibits the hormone sensitive lipase and prevent lipolysis in adipose tissue. So these are the areas, and it increases insulin increases potassium entry into the muscle and liver. So more excess insulin can lead to hypokalemia because it enhances potassium entry into the cells. And coming to the deficiency, insulin deficiency, we know it leads to diabetes mellitus, type 1 and type 2. Type 1 occurs in younger age. There is autoimmune destruction of beta cell. Treatment is only insulin. Whereas in type 2, it is non-insulin dependent diabetes mellitus. It is mainly due to insulin resistance. And coming to glucagon effect is opposite to insulin. It increases the blood glucose level, and it is like hormone of energy release. Whereas insulin is hormone of energy storage. It makes all the nutrients to get stored, whereas glucagon causes energy release, and it causes glucose in the blood, increased glucose in the blood, and it increases the fatty acid level in the blood, and it increases the amino acids level in the blood. And coming to somatostatin inhibit both the glucagon and insulin. It is an inhibitory hormone. And next we go for adrenal gland. So adrenal gland is made up of 2 portions. One is cortex, other one is medulla. So cortex is made up of 3 layers. One is zona glomerulosa, fasciculata, and reticularis. Glomerulosa is very thin layer, 15% composition, and widest layer is the fasciculata. The glomerulosa secretes aldosterone, which is a mineralocorticoid, and fasciculata secretes cortisol, which is a glucocorticoid. So the reticularis secretes androgen. They are the sex steroids that is helping in the reproductive function. And coming to the glomerulosa, the glomerulosa synthesis aldosterone. So mineralocorticoid in the sense it maintains the level of the minerals, sodium and potassium, and it increases the sodium reabsorption and enhance potassium excretion. It increases potassium excretion or secretion. So excess aldosterone, it leads to a condition called hyperaldosteronism. It's of 2 types, primary and secondary. So primary mainly occurs due to tumors of adrenal cortex, and this is called as Conn syndrome. And secondary is mainly due to increase in the renin secretion, and renin is stimulated in response to the body need, and this causes angiotensin 2 synthesis, and this angiotensin 2 will stimulate the aldosterone synthesis. So aldosterone synthesis exclusively occurs in the glomerular because of the presence of the enzyme aldosterone synthase. And in fasciculata and reticularis we have the other corticosteroid synthesis taking place, like the precursor of aldosterone is also produced in the fasciculata and reticularis layer, and the important raw material for the entire corticosteroids, the hormones for adrenal corticals hormones, the important raw material or the important source is cholesterol. So cholesterol is C27 steroid having carbon atom 27, and from the cholesterol we have pregnenolone, and from the pregnenolone progesterone, from the progesterone 11-deoxycorticosterone, and from 11-deoxycorticosterone we have corticosterone, then we have aldosterone. And similarly from the pregnenolone we have hydroxypregnenolone, and from the progesterone we have hydroxyprogesterone. This leads to the synthesis of cortisol, and the pregnenolone is also converted into hydroxypregnenolone, and that is converted into dehydroepiandrosterone. It is a precursor for the sex steroids in adrenal cortex, and it is a weak androgen. And a deficiency of the enzymes in any of this process leads to excess ACTH stimulation in response, and that leads to adrenal hyperplasia, and this is called congenital adrenal hyperplasia. So when the enzyme, for example, one enzyme called 21 beta hydroxylase, which helps in the conversion of this pregnenolone to 11-deoxycorticosterone, when it is deficient, the corticosterone 11-deoxycorticosterone is not synthesized, and that leads to salt losing form of adrenal hyperplasia with virilization will be there, because there will be excess sex hormones or sex steroids will be synthesized. Whereas in the next hormone 11 beta hydroxylase, which converts the 11-deoxycorticosterone into aldosterone, when it is deficient it leads to salt losing form of congenital adrenal hyperplasia with virilization. And the important rate limiting enzyme in this cortical hormone synthesis is cholesterol desmolase, and when it is defective the progesterone will not be synthesized, and the pregnancy will not occur, and there will be so cholesterol will be accumulated also, it is not converted into pregnenolone. And these are the some of the applied aspects in adrenal cortical hormone. And coming to cortisol, in the cortisol it is a very important hormone. It is a glucocorticoid. It is called glucocorticoid because it has a major role in the carbohydrate metabolism. It increases the blood glucose level, and it promotes gluconeogenesis. And this cortisol also, it is protein catabolic, protein catabolic, and it also helps in the lipolysis, lipogenic. It promotes fat synthesis, lipolysis, but in some areas there will be excess fat synthesis will takes place, and this phenomenon is called as redistribution of fat. So excess cortisol leads to a syndrome called Cushing syndrome, and if it is due to ACTH stimulated cortisol excess, it is called ACTH dependent Cushing syndrome. If it is not due to ACTH, then it is called ACTH independent Cushing syndrome, which mainly due to the tumors of adrenal cortex, tumors of the fasciculata, that leads to this condition. And what are the features of Cushing syndrome is there will be buffalo hump, that is a deposition of fat in the nape of the neck, and the moon's face will be there, and there will be centripetal obesity will be there, skin thickening will be there, and hirsutism will be there, and purple striae will be there, and hypertension will be there because cortisol have less mineralocorticoid activity, so hypertension will be there, and diabetes will be there because of excess glucose, and many features are there in Cushing syndrome. And when the entire adrenal gland is not functioning, that leads to a disease called Addison disease. It mainly due to the autoimmune destruction or due to tuberculous infection of the adrenal gland, and the features are both glucocorticoid and mineralocorticoid deficiency will takes place, and it has to be treated immediately. If the Addison disease patient due to the lack of these hormones, there will be excess of ACTH. Along with ACTH, MSH will be secreted, that is melanocyte stimulating hormone will be secreted, and this will stimulate the melanin, and this causes pigmentation, and the sodium will be lost from the body because of lack of mineralocorticoid. That leads to hypotension, dizziness, tiredness, and this has to be treated immediately, because low BP leads to shock and collapse and death. So what is Addisonian crisis is, this people with glucocorticoid and mineralocorticoid deficiency, when they go for any stress, any trauma or any surgery, they need extra dosage of glucocorticoids, and if it is not there, they will land up with Addisonian crisis, and immediate BP fall and shock and death will happen. So these are the some of the hormones I try to cover, and you also read some more hormones also, okay, which I have left in this video. Okay, thank you.